Hi guys, welcome back to our channel. Today we'll be discussing extraoral imaging. Okay, so we'll basically first be delving into the types of instances or situations that occur in the dental field that may require the use of extraoral imaging. Né? So firstly, we have avulsed permanent teeth. So an avulsed tooth, basically, ladies and gentlemen, is a tooth that has totally dislodged from the socket and can result in hypoxia and necrosis of the pulp of the tooth. It has associated injuries such as the fracture of the alveolar socket wall, as well as injuries to the lips and the gingiva. Ne? So normally, in treating avulsed permanent teeth, the patient will have to then come in. We examine the patient, administer local anesthetic, pour saline gently onto the avulsed tooth, and then we have to make sure that we re-implant this tooth within a space of 20 to 40 minutes. We then have to splint the tooth to immobilize it and allow for healing, which may take several weeks and may require the patient to come for frequent checkups just to monitor and observe how the tooth is basically going. But all in all, ladies and gentlemen, avulsed permanent teeth have a very, very poor prognosis. We have a 73 to 90% chance of poor recovery, so we may just lose that tooth. And most of the time, normally it's not just one avulsed permanent tooth. Normally such a patient would come with multiple avulsed teeth, so that actually even further complicates the story. From there, ladies and gentlemen, we may encounter mid-face fractures. So here they've listed a bunch of types of mid-face fractures that we may encounter in the dental practice or even in our clinics as well as hospitals, especially due to trauma such as car accidents, fights at bars and clubs and taverns, and so on and so forth. So firstly, over here, they discussed a Le Fort 1 fracture. So a Le Fort 1 fracture, ladies and gentlemen, is essentially the separation of the hard palate from the upper maxilla due to a transverse fracture running through the maxilla and the pterygoid plates at the level just above the floor of the nose. So it's basically a fracture that's going essentially across the maxilla. So that is a Le Fort 1 mid-face fracture. Then from there we have our Le Fort 2 pyramidal mid-face fractures. So here basically this fracture involves the transection of the nasal bones, the medial anterior orbital walls, the orbital floors affected, the inferior orbital rims, and transversely fracture the posterior maxilla as well as the pterygoid plate. So it involves quite a number of anatomical structures. Then from there, ladies and gentlemen, we have our Le Fort 3 craniofacial disjunction. So essentially over here, this type of fracture involves or impacts the nasal bridge or the upper maxilla and may involve the zygomatic ox as well. So it's a very complex fracture that we're dealing with over here. And then from there we have fractures of the zygomatic complex. So with the zygomatic complex, this is basically essentially the fractures of our zygomatic bone, either on one side or bilaterally. And then from there we have fractures that are associated with our orbital floor. So that is over there on the inferior aspect of our orbital floor, most commonly. So that would be like a punch in that particular area. And then from there they talk about nasal fractures. So this is basically a fracture of your nose, like I'm saying as well. A good punch over there to our nasal structures, also known as the nose, may basically cause the fracture of the nasal bone and or the cartilage associated with our nasal area. And then from there, lastly, we have our nasal-orbital / ethmoid fracture. I think is basically self-explanatory and may basically involve the fracture of the ethmoid bone. Ne? So basically, mid-face fractures, ladies and gentlemen, normally almost always result due to trauma, be it a car accident, people that have gone to war, be it fighting at clubs, and so on and so forth. And then from there, we have 3 buttresses that they are discussing over here. So these buttresses essentially allow the face to absorb force upon impact, or essentially once a force has been exerted onto our facial structure. So we have our nasal maxillary buttress. Then from there we have our zygomatical maxillary buttress, which is on the lateral aspects, as well as then the pterygomaxillary buttress that then exerts a force in the inferior superior direction. Ne? And then from there, ladies and gentlemen, we have our mandibular fractures. So like they say here, it is the second most commonly fractured area to the facial bone. And then from there, they tend to have multiple fractures in the mandible. Most of the time, ladies and gentlemen, mandibular fractures are how can I say, distinguished based on the location of the fracture line. Ne? So as you can see, there's multiple lines. So depending on where the fracture line is, that's how we'll then classify or denote a mandibular fracture. So we could say it's a mental fracture, or a symphyseal or parasymphyseal fracture, or we could essentially say it is a fracture of the body of the mandible, of the angle of the mandible, either of the ramus of the mandible, of the condyle of the mandible, of the coronoid process of the mandible. So that's one of the classifications we use to classify mandibular structures. This is just mandibular fractures, excuse me. This is just good to know, so that you're not lost. Hence, ladies and gentlemen, anatomy is very, very, very important, especially in maybe tertiary institutions. So this is just an example of a panoramic x-ray. It's not really, you'll find with patients that have undergone trauma, it's not that easy to get a very good looking pen. Their patient positioning will be affected because of all the fracture / the trauma that the patient has experienced. But try to get it as good as it possibly can, so that we can diagnose the fractures accordingly, as well as then manage the fractures accordingly. Okay. So then here they talk about how teeth and occlusion essentially are the key to reconstruction, and they essentially provide the foundation upon which other facial structures are built. I think that is very self-explanatory, but in layman's terms, they're basically saying where the fracture line is, which teeth are involved, which teeth were removed / destroyed as a result of the fracture, or which ones are able to decide or to survive, essentially, that are vital enough or appear to have a good prognosis. So those teeth essentially, and the occlusion of the maxilla as well as the mandible, basically that is the basis unto which we then try to manage this fracture and bring back the occlusion and the facial structures to their original harmony, or as best as we can. I hope that makes sense, but that's essentially what they were trying to explain. So then from there, this slide is basically showing you guys an example of a typical facial examination once the patient presents either to the practice or to the local clinic / hospital, what we could expect. So extraorally, we may look for, or your dentist may look for, lacerations, swelling, ecchymosis, which is underlying bleeding that is underneath the skin, any deformation, any other bruises, obviously, even the basics, which are the ABCs of, how can I say, of CPR or first aid, being airway, breathing, circulation, things of that nature. And then intraorally, your dentist may examine the soft tissues, the hard tissues, how they are looking. Hard tissues mainly being the underlying bone, as well as the teeth. Are there any mobile teeth? Are there any teeth that need to be extracted? Where the fracture line is, we may try to palpate it wherever possible. So those are some of, just a few examples of the things that we may look for during a facial examination. Then from there, okay, attitude, a little thing that makes a big difference. So just being professional at all times, even in our conduct, in our extracurricular activities, such as not drinking and driving. Okay, so here they're just asking you guys, in which dental specialities would extraoral imaging be used the most? I think that is very self-explanatory, especially with these x-rays. One, definitely orthodontics, because we want to monitor the growth of our patients, as well as the treatment that we've provided. As well, then, ladies and gentlemen, maxillofacial and oral surgery, especially with regards to our trauma patients. As you guys have seen, we need to see those fracture lines. We need to see which structures have been affected. We need to see how we're going to manage or which procedures that we may try to perform to actually try and bring or heal those fractures, or perform any other procedures. So the types of extraoral imaging that is used the most are your panoramic radiographs, as well as your cephalometric radiographs that are used extensively during oral surgery. Like I said, maxillofacial and oral surgery, as well as in orthodontics. Like I had mentioned earlier on, the new technology that's really revitalizing our industry are CBCT x-rays, but they are normally in academic institutions, but they also provide excellent extraoral as well as intraoral imaging. So that's another go-to that will shortly be part of this conversation sometime soon. Two other very important definitions, ladies and gentlemen, is those of anatomy as well as physiology. So anatomy is the study of the body structure, and then physiology being the study of body function, how the body functions. So you're basically asking yourself, why do I need to know this? Oh my God. First, ladies and gentlemen, in terms of radiographs, like you can paint a more holistic picture once you know what's actually going on. So this is very, very, very important, ladies and gentlemen. We expect you guys to know the purpose and the use of panoramic imaging, the equipment that is used in such imaging, the steps in preparing such a patient and positioning such a patient, because a lot of practices expect you guys to do this, and then describe the areas that you may encounter during patient preparation and positioning. This is very, very, very important. Okay. So to introduce you guys, extraoral images. So these are basically images that are or have been taken outside of the mouth. They are taken in large areas of the skull or jaw that need to be examined, or when the patient is unable to open their mouths for film placements, such as our edentulous patients, just a stupid example. So with extraoral radiographs, they are useful in evaluating large areas of the skull and jaws, but are not recommended for the detection of subtle changes such as caries, because with panoramic imaging, you can see caries, but it's mainly like moderate to severe caries. So your more minor or incipient caries will not necessarily show on a panoramic x-ray. And then from there, even early periodontal changes you would not expect to see on a panoramic image. And then from there has been an introduction, ladies and gentlemen, of full-featured digital panoramic units that are getting more and more conventional and popular in South Africa. And then a new technology known as CBCT. I think you guys heard me talk about it earlier on. So that is cone beam computed tomography. So essentially, as well, it assesses extraoral as well as intraoral structures, but it is right now, as far as I know, it's mainly in academic institutions. So almost all digital extraoral images have better resolution than the film-based images. So you'll find that it's more tedious, as in film images are more tedious in terms of processing and waiting on them, and you as the assistant having to deal with the fixer solution as well as the developer solution, and making sure that it is up to the standards of all the radiographic organizations. So it's a bit more tedious as opposed to the digital one, but mainly digital is not as conventional because it's a bit more expensive versus the film-based machinery.